we've done it, and it hasn't worked for decades, and that's called the war on drugs, and it doesn't work. And so, and the medical prohibition is fascinating too, in that a lot of this problem is also created by the idea that physicians have prescribed way too many of these drugs and they need to cut back on their prescriptions. Well, what a crazy idea that you people are addicted out there and you're telling them, actually we can't give you these drugs anymore, why don't you go find them somewhere else? And that's basically what we're telling people. And the other nuance in that, it's not just the people that were getting high dose prescriptions and were using them for their addiction. It's the many people who weren't addicted but were having their drugs diverted to the street. So that's way bigger of a problem. So we know from the people that have died in the last year in this overdose cohort, we're just looking at the data now, but about 10% of people had received a prescription for opioids from their doctor in the last 6 months. So very small proportion of people who have died were getting massive supplies of drugs from their doctor. They were getting pharmaceutical grade drugs on the street, but they were diverted from all kinds of sources. So this idea that doctors have now with this crisis, that our best bet is to cut back on the street supply of these pharmaceutical grade drugs, is driving the problem also. So it's a crazy situation that we're in. Having said that, it's, you know, I agree that overprescribing has created a lot of problems. So we have to look at, you know, what were the root cause of this? How did so much drugs get into our society? And we made mistakes, I'm sure. But now in this particular crisis situation, it's no time to try and reverse 20 years of overprescribing. And this is exactly what we would expect to have happen. So just to remember, this is a demand-driven thing, and our supply side responses are not going to fix the situation, and in this situation will make things worse. Every dealer who gets arrested today will probably equates to 2 more people dying of an overdose, because you have to go find another dealer now, and you don't know where they are. So the idea that we just kind of sweep up all the dealers is, again, creates way more problems than it solves. I just want to put a few graphs up there. These are things that people have seen before for sure. So this is just the latest from the coroner's office, looking at the number of deaths and this exponential rise over the last 2 to 3 years. And this year we expect about 1,500 deaths. And that is about 1 in 50 or 1 in 100 overdoses result in death. So we've done an amazing job with naloxone, and a lot of people come close to dying and then wake up, and they can often do that in their rooms. So there's a lot of close calls happening every day, and the people who actually die are at the tip of the iceberg. So this is a phenomenal thing when you think about 20,000 people last year getting and that's a 911 call. So this is, again, that probably is a gross underestimation of people who don't get a 911 call. So this is a massive, massive problem, and the 1,000 or 1,500 people that we talk about who died is just the tip of the iceberg. And the other, I don't think I have a monthly thing, but it's quite instructive just to look at probably for the last 12 months, the number of people dying each month is pretty flat. And from an epidemiologic perspective, that's a very scary thing, because most epidemics don't keep going on. So we've taken out 1,500 of the most vulnerable people in the province already. They're dead. And so to think that there's new people all the time to replace that epidemic is a pretty scary trajectory right now. And there's really, with the fentanyl and carfentanil on the streets, I don't see any change unless we change something. This graph is from ambulance calls, and again, just to illustrate how many ambulance calls there are. I'm sorry it's so small on the screen, but these are, the top of the bar there goes to 450, and these are monthly calls. But the other fascinating thing to me is these massive increases within a month. And it just shows you how fragile the drug market is. So we can go for a week in Vancouver and have very few overdoses. Some load comes in and 10 people die. So this is really reflective of a very unstable drug distribution and drug manufacturing market where people don't know what the hell they're doing. So they're mixing this stuff up in these clandestine labs, and the fentanyl and carfentanil is so potent, and you have to be so careful with the way you mix it up that even the smallest mistake results in people dying. And so over time, from week to week, as people mixing this stuff up, we can expect that mistakes will continue to happen, and getting the sweet spot of how much carfentanil and fentanyl you mix in with all your other powder is you should be a scientist. We need Walter White in our, and we do not have it. We have like really incompetent people mixing these drugs up, and so this is what we get, these massive influxes of bad or very potent drugs. This is what's happened in fentanyl, and I guess again just instructive how things have progressed over time. The graph, the bar graph there just really shows that we had very little fentanyl causing overdose deaths in 2012, and now year to date in 2017, 83% of the toxicology that comes back from somebody who's overdosed, died of an overdose, has fentanyl. So this is a total fentanyl catastrophe that has been replaced our regular drug market. And you can see that from this, also from the coroner's service, that the number of overdose deaths that aren't associated with fentanyl is pretty flat. So it was referred to at the opening that, you know, a decade ago we had 211 overdose deaths, and we'd be about there without fentanyl. So through the introduction and the poisoning of the street drug supply, it accounts for pretty much all the overdose deaths. So it's quite remarkable how fentanyl's done that. This is also from the coroners, just to giving an idea provincially what's happening, and the Kootenay areas at the top there. And the interesting thing about this overdose crisis is it is really provincial, and if you do graph this out by populations, it's pretty constant around all health authorities. About the same number of people per population are dying across the province. I was talking to somebody at the table just now, and one of the interesting things that has happened is that the downtown east side of Vancouver, which used to really be a massive concentration of people, is shrinking because of gentrification. And I went there first in 1999, and it's unrecognizable now. There's still housing for people, but the 15 square block area has been contracted to about 3 square blocks. So it still looks like chaos and so many people out on the street, but many of the places people used to live and hang out are no longer available to them because they're fancy restaurants and condominiums. And so that has really squeezed people, and they will go all over the province. So if you can't live in the downtown east side anymore because there's absolutely no housing, you could easily end up in Nelson, or you could easily end up in other places. So the demographics and the development and the expense of Vancouver is also indirectly responsible for this massive proliferation of people all through the province looking for places where they can feel that they can live or feel welcome or make a home for themselves. So there's been we have this problem is really provincial wide, and that's why we're talking in Nelson today. I just want to touch briefly on what's happened in the United States, because some of the statistics from there are even worse than here. Now, I think there is some nuances. I'm not sure if anybody's read the book Dreamland, but I highly recommend it. It's about the opiate epidemic in the United States, and how really there was massive illegal overprescribing by physicians. So these pill mills that developed in Ohio, Pennsylvania, West Virginia, where people would pay $250 and basically get any supply of opiates they wanted from doctors. They just paid cash, and it was a huge underground professional distribution of prescription drugs. And then the A small area in Mexico found out about all this addiction happening and started importing Mexican black tar heroin. And so that's what started killing people. The actual prescription drugs weren't resulting in overdoses. They were resulting in a lot of people being dependent on opioids. But it was really when heroin came in that this massive increase in overdose deaths happened. And again, another misconception we have in the public is that people taking a prescription drug are at high risk for overdosing. And that's, for most people who've had experience with opioid use, that's not the case. They know what they're getting, they know how to dose it, and they take it. And so the pills themselves are harm reduction. It's when people are buying stuff from the street that they have no idea what's in it when they run into trouble. But there's pockets in the United States that are just devastated and have worse numbers than British Columbia. These are graphs from the New York Times, just looking at specific places in Ohio, but you can just see this massive increase in number of overdose deaths in some of these very relatively small communities, and 800 deaths in Montgomery. And then it does get down to somewhat how much we've been prescribing, and I do acknowledge that overprescribing has contributed over time to more people becoming dependent on opioids. But my point was that now is not the time to cut that back. If physicians are actually responsible for creating this problem, then they have some responsibility to make sure that they support the people that they've impacted, and cutting them off their drugs certainly is not the thing that they should be doing. But the prescription patterns in Canada and the United States are way higher than other countries. So that's no one in U.S. obviously stands way above everybody else. And this is just one more graph looking at, again, the impact of heroin and fentanyl in the U.S. epidemic. And you can see that over time, this has got to about 2015, that pretty much all the excess overdose deaths are caused by heroin and fentanyl, and not all the drugs that started this in the first place, which were the Percocets and the Dilaudids and the Tramadol and all that stuff. A question that comes up is why now? And again, I refer to kind of the prohibition that we've done. So there's been, as I just showed, decades of rising opioid prescriptions. The delisting of OxyContin in 2012 was a turning point for many communities. So a lot of people were having a regular supply of oxys. In 2012, this was recognized as a problem, and that was cut off. The story around Purdue is a whole other talk, really. But Purdue Pharmaceuticals were driven to these pills that were less easy to crush, not so much because they cared about all the people misusing their OxyContin, but because their patent was running out and they needed to come up with a new formulation to extend their patent. And so they came up with the OxyNeos, which are not impossible to crush and inject, but more difficult and actually more hazardous when people do, because they contain all kinds of other crap. So oxys were very easily crushed and dissolved and injected. And so when those were taken off the market, it started this search for alternatives that, according to our graphs, really was a turning point in Canada for this overdose crisis. The stricter guidelines for prescribing really just came out last year, but there's been a lot of talk around the physician community that we really need to get people off these drugs, so that's been going on for several years. An inconsistent heroin supply, which kind of are above what we understand, but I think the basic concept, how hard and organized you must be to get Afghani heroin into the streets of Vancouver or the rest of British Columbia, we could all understand from an operational point of view that must be quite difficult. And so they've decided that fentanyl and these synthetic compounds are much easier and much more profitable. So that making fentanyl is just pennies, and on the street it's sold for pretty much what heroin used to be sold for. So you can just imagine the profit margin now that the dealers are having. So if it's driven by profit, then it's so obvious that fentanyl and even carfentanil would be the drug of choice for people trying to distribute opioids. I just want to touch on our approach to this, and in the context of something called moral panic. And so the public has been inundated with headlines about fentanyl. So fentanyl has become sort of the new devil. And it's really forced us back into the war on drugs. So instead of it's taking our eye off the fact this is a demand-driven thing, these are poor, traumatized people that we need to be helping, it's really refocused our attention on, well, why don't we just go after fentanyl? So this is a moral panic, and the general public has all heard about fentanyl, and they don't care as much about poverty and homelessness and trauma. They care much more about how can we get this at this drug. And this has happened over and over again. And there's a guy named Cohen in the 1970s who kind of went through this cycle of moral panic. And it's really what's happened to us. So a crisis or event happens and it's reported in the media. We have a sensification, so the public becomes more sensitive to this issue. Then we start a witch hunt. So deviants in society are found and become folk devils and scapegoats. So that's the drug dealers and people who are importing the drugs and the people using the drugs. These are the deviants in our society. This is amplified by, again, the media, but leaders in our community, doctors, police, social media, and the government comes on board, defines the deviant issue, and now it appears as a fact. This is really about fentanyl. And then panic ensues, so the deviant issue is escalated, the original problem disguised, and there is now public panic. And then the government or our legislation comes up with a response. So punishment is agreed on, we take action against the deviants, and then we wait for another crisis to appear. So we're in this cycle right now with the fentanyl moral panic about how we're going to deal with this, and it's really become a crisis. But the problem with this approach is it really takes our eye off the drivers and how we're supposed to do this. And certainly scapegoating dealers and scapegoating the people using these drugs is not the way forward. We've seen this before over and over again, so with crack kids, youth crimes, cyber porn, the meth epidemic. This is all just repeating history all over again, and we've been through this before. And at the end of the day, many of the drivers for all of these things have been left untouched. And we've just focused on this particular issue, and we've tried to come up with ways to solve that issue. In these kind of examples, I was just thinking last night when I looked at the slides, I don't think there's very much that we did to make any, these just kind of continue, but they're just not in the public eye anymore. And there's still youth crime, there's still lots of people using meth, there's still kids, their parents using crack. I mean, these kind of things have just got to take a media cycle, and then people lose interest and we go on to something else. I'd like to turn for the next bit to what we've done in BC from a very high-level perspective, and many people in the room have been involved in these. But these are the three things that I think are key points to our response. So the first was this public health emergency announcement by the then Health Minister Terry Lake and Perry Kendall, the Chief Medical Health Officer. So BC was the first to take this action. I was at a number of tables pushing this idea that we need to make this an emergency. The quote here, I won't read it, but it really, the emergency was focused on collecting data. So the government wasn't that keen on committing to like many changes or many kind of emergency interventions, but we could get them to gravitate around the idea that we at least need to know what's going on. And a public health emergency would allow us to break down some of the barriers to collecting data. So you wouldn't believe how hard it is to get data from a coroner's office, for instance, and from the ambulance service, and from the police, and from all these sources. And we still, to this day, have a lot of struggles getting real-time, up-to-date data about what's going on, because each of these silos and each of these groups that collect this data traditionally have not had to share it or link it. And it's fascinating to me also, dealing a lot with the coroner's office, how protected people who have died really are. So it's very difficult to get any details of somebody who has actually died because of privacy concerns, which in my estimation, would be the least of our concerns from somebody who's already passed away. But there's this massive legislation in place that they don't really want to release any information about the person who has died unexpectedly in the province. So that's been, so that the whole impetus to this emergency response really was to collect better data. It's opened up other things, but that was a turning point, I think, for our response in British Columbia that happened in April of 2016. The other thing that we've been quite successful about and quite known for is our naloxone program. And Jane Buxton and her group at BC CDC had been doing this for many years before, anyways. But it was it happened. The overdose epidemic happened at a time when we really needed naloxone. And this is a graphic that's updated every month. But so 57,000 naloxone kits have been distributed. That's just the take-home program from the BC CDC. So there's programs now where pharmacies and different places can give out naloxone, but this is just coming out of our basement. There's almost 60,000 kits, and 11,000, almost 12,000 have been used to reverse an overdose. So without naloxone, those numbers would be far worse. Obviously, not every naloxone intervention, a non-invention would have resulted in an overdose death, so, but some would have. So the naloxone response has been extremely important in British Columbia, and we're far ahead of other jurisdictions about our naloxone. Police are on board, fire's on board, so we really had a pretty good response to naloxone. This is just wanted to mention Dougie Nickerson from Surrey, who really is a trooper who he's out of province now, I think, but he's has reversed. I'm sorry.
He died.
Of cancer. Doug died of cancer, what, 3 weeks ago, I think? There's a big memorial this Saturday.
Wow. Okay, I'll have to change my slide to acknowledge that. So.
And there's more than 113, too. Just saying.
So this was a bit outdated. I'm sorry about that, but
it's hard to keep up with this guy.
yeah. The issue around, we're very proud of the response to the community, and we have an army of people who are street entrenched people who are out there saving lives. I don't think we've done a great job of supporting them. Some of this work should be taken up by our health responders, not so much put back on the people that are less, not really equipped to deal with this very well. And there's been a lot of trauma that we've inflicted on people who have been reversing overdoses for us. And with no, we pay an ambulance person a lot of money to rush to an overdose and save that life. We pay Dougie and those people nothing to do it, and rarely thank you. So although it's been, I think, a really important community response, and it's really given people something to rally around, I think there is a downside to how we've offloaded a lot of the work that we should be doing and not recognizing the trauma that we're putting people through and not supporting them the way we need to. I apologize for this slide about Doug, but I'll update that. The other thing that's happened is these overdose prevention sites. So I think that is another one of the probably the main thing that came out of Terry Lake's office during this emergency response. So December of 2016, he announced that we'd be able to basically break the law and open these sites, because there's a lot of discussions. I was at the table, there's no getting around that these are illegal. There's no exemption. When you think of all the hoops that we went through for Insight, and all the hoops that we're going through to try to get Health Canada exemptions for supervised injection sites, this just bypassed the whole thing. And there's about 22 of them happening here. I think it's a fascinating social experiment. In all but a couple of examples, there's really been no community pushback for these things. I mean, the community didn't have time to organize. They just showed up, and they've been highly successful. And the one that Sarah Blythe and Ann Livingston were responsible for sees more people than Insight now in Vancouver. It's just across the road, basically. And so these have a life of their own, and there's all kinds of models that we can develop. And it was Alex and I mentioned this yesterday, but there's no legal reason that that couldn't happen in Nelson in a way that suits the needs of the community. So if it was an Insight was opened on Baker Street tomorrow, my understanding is there wouldn't be lineups out the door to get into that. People are scattered and hidden, but there could be small projects scattered around that meets the needs of particular people. So those that are using don't have to go into washrooms and alleys and things. So there's the overdose prevention sites have a wide girth right now of what we can actually do, and there's no provincial legislation that would stop people from opening them. I've been at the supervised injection site discussions for way too long, since Insight opened in 2003, and basically I think you need to pin people down who oppose these things, because if you support harm reduction as a whole, including needle exchanges, it's not possible for you to be opposed to supervised injection sites. These are needle exchanges, basically. So if you're in a position, or you're talking to somebody who does not want to support harm reduction, we're kind of, we can argue and talk back and forth and try to convince each other of the pros and cons of harm reduction. But if you have somebody in front of you who admits that, oh, needle exchanges are a great idea, I totally support those, I got ya. This is a needle exchange. It's just a little bit more step, that instead of saying, here's your needle, go buy some drugs and go in an alley, we're saying, here's a needle, unfortunately right now go buy your drugs, but here's some place at least that we can watch you. And where we had some interesting conversations, the provincial government was coming up with a public campaign that said, under the current circumstance, if you're using drugs, don't use alone. Always have naloxone and have somebody who can call 911. That's a supervised injection site. So it was totally incongruous that you could have these billboard messages and say, oh, but by the way, the only place in the province you could ever do that is Insight. Like, so we can really push this issue hard, I think, and I've become quite skilled at backing people into a corner, so I can give you my talking points. But I mean, if you can support needle exchanges, you have to support a place where people can be supervised to use their drugs. It's just common sense to me. So I think this has been one of the big impactful things, and this kind of movement is growing across the country. I was in Toronto last week and visited Moss Park in Toronto, and so these things are starting to gain some traction across the province, across the country, and BC's at the center of these things. One of the pitfalls right now is the Health Canada, though, is moving more quickly on exemptions of supervised injection sites. So imminently, or a couple just came down, but there'll be 5 or 6 Health Canada sanctioned supervised injection sites in the province. Unfortunately, they come with a list of restrictions and barriers for people. So we're at a position now where we've been so successful with these overdose prevention sites that getting an exemption could be the kiss of death for some of these things, because now you have all kinds of rules and regulations that aren't applicable to these overdose prevention sites. So we're at a bit of a tricky point here. We're really pushing hard for Health Canada to give these approvals and exemptions, but they have quite a standard procedure about how these work, and some of them are barriers to people currently using these other sites. So we don't want to say, well, this was working so well, but now we don't need it anymore because we have an exempted site over here. That will be problematic for a lot of people currently accessing these services. So I'd like to turn now to 10 points. It kind of summarizes some of our approaches, and this came from we called it a BC Overdose Action Exchange, and the last one, we've had 2. This one happened in June of 2017, and it was a gathering of about 130 people, much like this. We tried to have a really good representation from people with lived experience and people who are currently using drugs. But in the audience, we had 12 or 15% of the people there were lived experience, so that was really important to us. But a wide swath of academics and politicians and policymakers and frontline workers at this. And we came up with 10 action strategies, and so I'd just like to quickly go through those. So the first thing is peer engagement. So it's interesting being in the healthcare world where patient needs and patient input is like #1 at hospital boards and all this. And somehow with drug use, we have kind of ignored that, and we've made decisions for people that often are not very useful for them. So at the #1 thing was that we need to have people at the table and actively engage in our response who are on the ground, know what's happening, and